Thank you, ma'am, for those kind words. And I thank the organizers for this opportunity to speak at this CME. My talk would include a brief introduction of thyroid physiology. Then we go on to dysfunctions and how do we interpret those tests. And no other biochemical testing in endocrinology has so much of interference of assay interferences as thyroid hormone. Then we talk a little bit about special situations, because we know that age and various other factors affect the thyroid functions as they would affect any other physiology. Okay. So just a few words about the thyroid physiology. We know that thyroid gland is highly conserved in all vertebrates because thyroid hormone is required for all kinds of cell activities, be it multiplication, growth, maturation, development, as well as all kinds of energy requirements are met. And to begin with, in the development of animal kingdom, earlier we were waterborne animals where iodine could be reabsorbed and it was freely, abundantly available. But over the years, when we became terrestrial animals, we required systems to concentrate iodine. And humans, I think, are the ones who have iodine deficiency disorders the most. And UP is a hotbed seat for iodine deficiency. So we really need to have adequate iodine in our diet to prevent a lot of problems associated with iodine deficiency and thyroid hormone dysfunction. The thyroid hormone is very tightly regulated. It is controlled by the TRH, which is the thyrotropin releasing hormone, which is secreted from the hypothalamus. It acts on the thyrotrope cells in the anterior pituitary, which secretes the TSH. And then this TSH acts on the thyroid follicular cells. And every function of the thyroid gland is controlled or stimulated by the TSH. It causes the cell proliferation, cell hyperplasia. It increases the sodium iodide symporter expression so that more of iodine is trapped into the follicular cells, and it increases the iodination and coupling so that it stimulates the secretion of thyroid hormone. The hormones which are secreted from the thyroid gland are predominantly the T4, and less amount of T3 is secreted, although we know that T3 is the bioactive hormone. So peripherally, the T4 is converted into T3 by the deiodinase enzymes. And since T3 is the bioactive hormone, peripherally the T4 is converted into T3. And again, this conversion also is stimulated by the TSH. All these things are important to know because when we see the dysfunction, we will understand what is the role of this tight regulation of thyroid hormone. The thyroid hormone which is secreted acts negatively to decrease the secretion of TSH as well as TRH. Every person has a set point of TSH secretion. Some need a higher level of T4 to control the TSH secretion. Some require a lower. So that is why we have wide ranges of TSH. The normal range is from 0.4 MIU per liter to 5 or 4.3, depending on the assay which you use. So when the T4 or T3 is low, there is less of negative regulation, TSH is high and TRH is high. If the pituitary is dysfunctional, that means if you have secondary hypothyroidism, the TSH is low as well as the T3, T4 are low. So T4 and T3 circulate in the circulation bound to proteins, the thyroxine binding globulin, which has a high capacity, low affinity, then albumin and pre-albumin. As I said, free T3 is the most metabolically active, and the conversion to T3 is important for its action. The various tests for thyroid function, the biochemical tests include the measurement of thyroid hormones, TSH, thyroglobulin, as well as measurement of antibodies. And the functional tests include the radionuclide scans, which include the radioactive iodine, as well as technetium label scans. The structural assessment is done by thyroid ultrasound or the CT and MRI. Now a thyroid clinic is not complete if the thyroid physician doesn't do an ultrasound. That is, gradually people are learning to do their ultrasounds in their own clinic so that a complete assessment of thyroid dysfunction can be done and the disease can be interpreted and treatment can be given. So I will concentrate only on the biochemical tests of thyroid hormones. So for thyroid dysfunction, when we have high T3 and T4, as I said, with the negative regulation, the TSH is low. So that is thyrotoxicosis. Primary hypothyroidism, when the thyroid gland is dysfunctional, you have low T4 with low negative regulation of TSH secretion. You have a high TSH. And when the pituitary is dysfunctional or the hypothalamus is dysfunctional, the TSH is low and the T4, T3 also are low. But in nature, nothing is so simple and clear-cut. Everything is as confusing as possible. So let's see what kinds of confusion thyroid hormone profiles can present. Generally, thyroid hypothyroidism or decreased thyroid hormone levels generally cause vague complaints of body ache, some amount of weight gain, and joint pains, cold intolerance. If a patient walks into your clinic with generalized edema, sore voice, dry skin, it's no biggie that you diagnose the patient as hypothyroidism, but not all patients come like that. You do a TSH and you diagnose it. But mostly patients present like this, some amount of facial puffiness, some joint swelling, some joint stiffness, and always TSH is the first test which you diagnose. In our own laboratory, we do about 3,000 TSH evaluations or assessments every month. So you can understand that the number of TSH done routinely all over in population is so high. So interpretation is very important. So when a patient presents like this, TSH is the first test to be ordered. And if the TSH comes more than 60 or sky high TSH, the diagnosis is very clear. You diagnose the patient as primary hypothyroidism. To find the etiology, if there is goiter, you do a thyroid peroxidase antibody measurement to know whether the patient has autoimmune thyroiditis. If the gland is not palpable, you say atrophic thyroiditis, go ahead and just treat the patient with levothyroxine therapy. But suppose the TSH just comes bang normal, then does it rule out hypothyroidism? Yes, it rules out primary hypothyroidism, but doesn't rule out other conditions associated with hypothyroidism. So what next? We do a T4, total T4. That also comes low normal. So what do we make out of this low normal T4 and a normal TSH? Two conditions. Euthyroid hypothyroxanemia. As I said, that TBG is the predominant protein which binds T4. If you have any condition which leads to decreased TBG, the total T4 will be low. But then you can differentiate by estimating a free T4, which will be normal in a patient who has TBG deficiency, but low normal free T4, low free T4 and a normal TSH was point towards secondary hypothyroidism because the TSH is low, that is why the free T4 is low. And this normal TSH is an inappropriate TSH for a low free T4. As we saw in the regulation, that if the T4 is low, the TSH should go up. But if the TSH is inappropriately normal or not higher than, say, 10 to 15 milli-IU per liter, you should always think of secondary hypothyroidism. And secondary hypothyroidism, isolated secondary hypothyroidism is very uncommon. It is usually associated with other pituitary hormone deficiencies. So the next step to do to diagnose whether it is really secondary hypothyroidism or what is the cause is to do an MRI or a CT, which would reveal a pituitary mass, which would make you confident that this is secondary hypothyroidism. You evaluate for other hormone deficiencies and treat accordingly. Same thing I wanted to highlight in children who come with short stature. Other than other causes for short stature, important endocrine causes would be primary hypothyroidism and growth hormone deficiency because of isolated or a part of other pituitary hormone deficiencies. Again, here doing a TSH will fool you. So T4 is the treatment of test of choice because it will tell you that the child is euthyroid or hypothyroid, and then you go ahead and evaluate further. Suppose the same lady came with a T4, which is 70 nanomoles, which is in the normal range, TSH, which is 10 milli-IU per liter, same lady which we saw earlier. The TSH is more than the normal range because the normal range is up to 4.5 milli-IU per liter. We did a free T4, which is normal. That is, the lower limit is 10. So what is this now? Low normal T4, normal free T4, and a TSH of 10. It is subclinical hypothyroidism. That means the patient doesn't have obvious clinical features of hypothyroidism, the T4 is normal, but the TSH is high. And T3 is also normal. As I said, that the body tries to conserve the active metabolite. So as the TSH rises, the T4 to T3 conversion increases. And even in the evolving stages of hypothyroidism, you may have low T4, but a normal T3 and a raised TSH. So this also goes in the direction of an evolving hypothyroidism. Just a word about that, all patients of subclinical hypothyroidism do not require treatment. There are few conditions where treatment should be offered to the patient. And always remember that subclinical hypothyroidism doesn't mean a lifelong therapy. Give the treatment trial for 6 to 12 months. Always counsel the patient that we will stop the treatment, reassess. If the TSH rises again, then that means you need lifelong treatment. Other causes of raised TSH with a normal or a low free T4 would be, important one would be the patient is on treatment with LT4. Commonly happens if you have to take a medicine lifelong, you're bound to forget the treatment. So patients, and when they know that they have an appointment and they have to come and see the doctor, they would start taking the treatment religiously. So the T4 may be normal, but the TSH has not had time to recover from a high to a normal level. So the similar picture you may get on a patient who's on LT4 treatment or levothyroxine treatment, but a non-compliant patient. So you can get a normal T4 and a marginally or a raised TSH. You have to go back and ask for compliance. That is one of the commonest things because we have so many patients who are on treatment. So it should make you suspect non-compliance. Then malabsorption of T4. Again, it will be the same condition like not taking treatment. Obesity, because the set point for TSH secretion is higher in obese people. So the TSH may be high. And the other condition which people need to think is non-thyroidal illness in the evolving stage. Earlier, in the early stages of non-thyroidal illness, you get a low free T4, low free T3, and a low TSH. But when the patient is recovering, the first thing to rise is TSH, because that is the one which is going to stimulate the thyroid gland to produce more hormone. So if you have a low normal free T4 and a TSH of 8 to 10, you have to go back and take history of critical illness. The thing which I want you to pay emphasis is macro TSH, which is important for pathologists when they are assessing, having an assay for TSH. So this is something similar to macroprolactin, where you have the monomeric TSH bound to an antibody. So you form a large circulating form of TSH, which has a long half-life and is biologically inactive. And none of the platforms which are available, automated platforms, can easily distinguish between normal TSH and a macro TSH. So you have a normal or a high normal T4 with a raised TSH. So you have to think of macro TSH. The various ways by which you can at least get an idea of this interference is to use a dilution method. That means you dilute the patient's serum with the diluent provided by the manufacturer. And when you run it, normally if the patient has normal or doesn't have macro TSH, it should be a linear curve. But that doesn't happen when you have a macro TSH. The other thing which commonly used for macroprolactin is a PEG precipitation. When you add PEG, polyethylene glycol, the large molecules bind to that and get precipitated. So when you measure the TSH in the eluent, it will come low. So if the recovery is less than 25%, it makes you think that this serum had macro TSH. But still, there are situations where it may not be so clear cut, and 25% is a ballpark figure. Different labs have to set up their own standards of cutoff to say that below this recovery, we will suspect macro TSH. The other sort of confirmatory test is to do a gel filtration chromatography, where the samples will separate on the basis of the mass and the weight. The other method to do is to incubate the patient's serum with a known hypothyroid patient who already has high TSH. So when you incubate the serum for 4 hours, this immunoglobulin which is there, which is causing the macro TSH, will bind to the TSH in the patient's serum. And then when you assess or estimate the TSH, it will come low. And the heterophil antibody interference will not show this kind of a fall, because in gel filtration, the human anti-mouse antibody actually co-elutes with the macro TSH. So again, if you have so many of the patients can have heterophilic antibody against mice, so then again, it will be difficult to interpret. So then this incubation technique comes in handy. So after having seen how hypothyroid hormone profiles can be confusing and what are the ways to understand it, we come to the thyrotoxic profiles. This is a lady who presented with history of palpitation, tremors, clear-cut history suggestive of thyrotoxicosis, and which is a strong possibility. The important thing to diagnose in this patient is what is the etiology of this thyrotoxicosis, because the treatment differs with the kind of etiology the patient has. So this is a hormone profile, which is clear-cut thyrotoxicosis. We are happy. We go ahead and start antithyroid drugs, carbimazole. No. If the patient doesn't give a clue to the etiology, we have to do certain radionuclide tests just to know what kind of etiology, because the treatment will differ. This is a clear picture of Graves' disease or a diffuse thyrotoxic goiter, which picks up the whole radionuclide scan, and the salivary glands up here are hardly visible. This is if the patient has a solitary functioning thyroid nodule. Here, the treatment of choice would be a radioactive ablation. And this is where there's no uptake at all in the thyroid bed. This patient has subacute thyroiditis. The thyrotoxic profile is because of the destruction of the thyroid follicles. The whole of the thyroid hormones are there. This patient doesn't warrant antithyroid drugs, because this is a self-resolving condition. The majority of the patients over a period of 3 to 6 months would become normal. Some may have a hypothyroid phase where they may require treatment, or you may just follow them up and they will become hypothyroid. Only 10 to 15% of these patients become permanently hypothyroid. So these patients just need to be followed up and given symptomatic treatment with beta blockers and pain relief. This is another patient who comes with history of eye symptoms, with proptosis in the right eye, and has a goiter and has mild tachycardia, but no other features. So we think of a possibility that this patient could have Graves' ophthalmopathy, and we go ahead and investigate him, where the T3 and T4 are absolutely normal, and even the TSH is normal. So what does this patient have? Does he still have Graves' disease and ophthalmopathy or not? This kind of a picture is common or is seen in patients who have euthyroid Graves' ophthalmopathy. Graves' ophthalmopathy, 3/4 of the patients present with simultaneous thyrotoxicosis, but 10 to 15% of the patients may present with ophthalmopathy, be euthyroid, and then develop thyrotoxicosis later on. And less than 2% of the patients may not ever develop thyrotoxicosis. They may just have ophthalmopathy and get treated over the period of time. And nearly 10 to 15% patients may develop ophthalmopathy later on. And the second possibility, which is more likely, is that this patient is a patient of Graves' of thyrotoxicosis and is on treatment. So the TSH has become normal, and these T3 and T4 are normal because of giving antithyroid drugs. So these are the two differentials when you have a patient who looks like to have Graves' disease, and this is the kind of a biochemical profile you get. So this becomes the interpretation of this biochemistry. Here comes the role. If the patient is euthyroid, or if the patient doesn't have ophthalmopathy or dermopathy, you want to know whether this patient has Graves' disease or is thyrotoxic because of any other cause. Here comes the role of measuring thyroid receptor antibodies, the TRAB antibodies as we call, because that tells you that this patient has autoimmune thyroiditis or Graves' disease. What are the other indications of doing TRAB antibody measurement is, when as I said, we do a nuclear scan, which showed a diffuse uptake, that tells you that the patient has Graves' disease. But if the scan doesn't show a good uptake or doesn't clearly show an uptake, then TRAB positivity helps you reach a diagnosis. Absence of ophthalmopathy, to predict a relapse. Suppose a patient who is TRAP positive continues to be TRAP positive at the end of the treatment, you can, with reasonable amount of certainty, say that this patient is going to relapse whenever you stop the treatment. So some kind of a definitive treatment this patient requires. In pregnant women, it helps to predict neonatal occurrence of thyrotoxicosis. And in neonates, it helps to differentiate between endogenous thyrotoxicosis and thyrotoxicosis due to maternal transfer of antibodies, because treatment and the monitoring will depend on the etiology of neonatal thyrotoxicosis. So this was about just clear-cut thyrotoxicosis, but then there are situations where you have suppressed TSH and the T4 may be normal or marginal high normal. Then what are those conditions and how do you interpret these results? When you give exogenous levothyroxine therapy to a patient who is primary hypothyroid or secondary hypothyroidism, you can't give the thyroxine in a way the body titrates the levels of thyroxine and TSH. So exogenously administered thyroxine will always lead to a high normal or a high T3, T4 and a suppressed TSH. So many patients who are on thyroxine therapy, when they get this report done to monitor whether the dose is adequate or not, are unfortunately put on anti-thyroid drugs, suspecting that the patient is now thyrotoxic. No, it is just that you're giving exogenously thyroxine hormone, you're bound to get a high T3, T4 and a suppressed TSH. So when you see a report, a history of thyroxine replacement therapy is very important. So when actually the form should contain, are you on thyroxine replacement therapy? One of the information. The other entity, as we saw, is subclinical hypothyroidism. Sorry, it should be hyperthyroidism. Is subclinical hyperthyroidism, where there are pockets in the thyroid gland which are producing more hormone, but the level of the hormone is not so high. And as I said, that the TSH or the pituitary gland is very sensitive to hormones. So as soon as it starts reaching a high normal value, the TSH starts, the levels of TSH start going down. So you may get a suppressed TSH with high normal T4 and the patient could be subclinical hyperthyroidism or thyrotoxic. And in the initial stages of non-thyroidal illness, as I said, that initially in this stage, the free T3, T4 are low and TSH is suppressed. In the evolving or in the recovery phase, the TSH is the first to rise. And very important for all people dealing with assays is assay interference because of biotin, streptavidin, or heterophil antibody. So how do these assay interferences occur? This is a sandwich immunoassay for TSH, where you have a capture antibody. This is the antigen or the TSH, which binds to the capture antibody. Then you add the label antibody is added, which binds to this complex, and it binds to the TSH at another site than the capture antibody. And then you have a reaction, whichever, electrofluorescence, chemiluminescence, or ELISA, whichever, the reaction is red. So the concentration of TSH is directly proportional to the reaction which is produced. So in a TSH assay, you can have interference at all these levels. You can have interference when you have anti-streptavidin antibody, because then it will bind here. This bite, and in the TSH, what you have are these magnetic beads which are labeled with streptavidin. Biotinylated capture antibody binds to the streptavidin. Then you add TSH, it binds to this capture antibody. You have the labeled antibody with ruthenium, and then you get the reaction and you read it. So at all these steps, you can have interference. What I'm more interested here is to talk about biotin, which is being very commonly used these days for various reasons. Biotin is sort of a wonder drug for skin, nails and hair, skin, nails and hair. So it's become a very common dietary supplement. And you never get to know how much biotin has been added to these dietary supplements. And patients actually don't consider dietary supplements as therapy. So they will not even come out with history that they are taking biotin. And you really have to dig into it. And the best way to do is what I follow in, and we generally follow in the clinic, is to ask patients to stop taking all what they have been taking as supplements multivites or whatever for 3 to 4 days before they come for their sampling, because that is generally the washout period for biotin. And actually, biotin is used because it binds to the streptavidin and it's a very strong reaction. So the capture of TSH is very good. So if there is any interference with biotin, the high concentration of biotin actually will bind with the streptavidin and you will not have the capture antibody bind to it. So you will have less of TSH bound, less of the reaction. So less the reaction, less is the value of TSH. This is in reverse to what happens in a competitive immunoassay, which is used for measurement of free T4, T4 and T3. Here, the sample and the labeled antigen both are added. This is a one-step method where they are added together. The antigen, labeled antigen and the analyte bind to the capture antibody, and then it is washed. And the labeled or the bound is stuck to this antibody and the reaction is red. So lower the reaction, higher is the concentration. It's the reverse of what we get in TSH. So if you have biotin here, it will bind to this antibody and the labeled antigen will not be able to bind. So the reaction or the amount of reaction will be less. So less the reaction, higher the concentration. So what you would get is higher free T3, T4 and a suppressed TSH. So you would get a picture like thyrotoxicosis. You would get a picture which is similar to thyrotoxicosis. And as I said earlier, that you do a trap to detect whether the patient has thyrotoxic or not. Unfortunately, TRAB also will give a high value because it is similar to how you do a T3, T4. So you would have a high free T3, T4, a high TRAB and a suppressed TSH, very clearly like a thyrotoxicosis, and the patient would be put on antithyroid drugs. So the bottom line is, if you're not convinced that the patient has thyrotoxicosis because of the history, the other things, the two things which you could do is do a radionuclide scan, which will tell you whether there's increased uptake and tell you whether it is Graves' disease or not, or suspect seriously biotin interference and use various methods to avoid or to interpret the results. One is to take a significant and an in-depth history and give a washout period so that there's no interference. Use a different platform. You need to choose a platform which does not use biotin streptavidin method for capture antibody. Or the third step is to add enough of streptavidin to the serum sample, which will bind the biotin and then do the assay. So you will not have interference of that biotin circulating with your assay platform. So just a few words about how to avoid these assay interferences. One is to repeat a test, take a detailed history and try to interpret it with the clinical condition. If after all this you strongly suspect interference, use a different platform and then compare the results. If they are same, then you have to use other methods. And if the results are discrepant, your suspicion is correct that there is interference because of certain analytes which are present. The other method, as I told you earlier, was serial dilution. The next one is adding blocking agents. You either add hypothyroid serum for macro TSH, or you have commercially available heterophil blocking antibody test tubes where you add the serum and then analyze or assay the eluent. The other methods to deplete the antibodies are precipitation, gel filtration chromatography, or affinity extraction by adding, say, streptavidin as we added to when biotin is a suspect. After all this, this is just a diagram to show you what kind of interference, what kind of thyroid hormone profile you get, and what are the various assay interferences or interpretations which you make, and what are the ways to avoid or come over these interferences. I have dealt with this earlier, so I won't go in detail again. So a word about special situations. Thyroglobulin is this is just talking about when you follow patients with differentiated thyroid cancer and you do thyroglobulin as a marker for remnant disease or a recurrence of the disease. In a patient we were following up in endocrine surgery. This is a patient from our sister department, where they found that the thyroglobulin was undetectable. So does this mean that there is no remnant or the disease has not recurred? No, because the presence of antibodies to thyroglobulin interfere with the measurement of thyroglobulin, and you have falsely low levels of thyroglobulin. It works in the same way as I showed you in the antibody assay interferences. So always when you're following patients of differentiated thyroid cancer, you need to do thyroglobulin and you need to do thyroglobulin antibody simultaneously. So if the thyroglobulin is undetectable, measurement of thyroglobulin antibody helps. A rising titer of thyroglobulin or a measurable amount of thyroglobulin antibody should make you suspect that this patient has recurrence of the disease. And then you further follow up by doing iodine scans. If they are negative, you do a PET CT to localize the disease and manage this patient further. A 26-year-old female with first trimester of pregnancy of 10 weeks of pregnancy presents with a biochemistry report of high T4 and a suppressed TSH. How do you interpret it? Is it thyrotoxicosis or is it a normal thyroid physiology? Most likely it's a normal thyroid physiology in pregnancy, because thyroid binding globulin starts increasing in pregnancy, which begins by 8 to 10 weeks of gestation. Because of raised estrogen, the TBG rises. So you have a high T4 and the HCG has intrinsic thyrotropic activity. It is very similar to TSH. It binds to the TSH receptor and stimulates the thyroid gland and in turn inhibits the TSH. So a high T4 and a suppressed TSH doesn't mean that the pregnant woman is thyrotoxic. It just means that it's most likely that it is just similar to a normal thyroid physiology happening in pregnancy. But yes, if she has clinical features, you need to do TRAB and all the exercise all over again. So significant homology between hormone-specific beta subunit of HCG and TSH. So you have high concentrations and the picture is very similar to thyrotoxicosis. So, and a word just about thyroid function in neonates. I can't stop talking about, or at least our department, ped endo people cannot stop talking about neonatal screening for congenital hypothyroidism, which should be followed practically by everyone. So how to interpret those tests? The TSH levels actually depend on the gestational age and the time when the sample was taken. Because as soon as the fetus is out or the baby is born, there is a surge of TSH which takes some time to settle down. So first of all, when should you, I won't go into the depths, maybe just introduce you to this topic of neonatal screening, that you really need to interpret the TSH values based on the gestational age as well as the time when it was collected. And there are cutoffs given for different gestational ages as well as when you collect the sample. And when should you retest? It's a whole different talk. And the second thing, that total T4 is high in newborns and it remains high for the first year of life. So levels are high in infancy and they are much higher than in adults. So to conclude, I would say that thyroid function tests are freely available, but their interpretation requires knowledge of thyroid physiology. Results really need to be clinically correlated, and with the use of antibody therapy, so many humanized monoclonal and antibody therapy being used for different diseases. Interference from these antibodies is significant, so we should be aware of these assay interferences. And euthyroid hypo and hyperthyroxanemia are common, which are physiological, and we need to understand it and to manage the patient accordingly. And etiological diagnosis requires ancillary tests.
Thank you, Dr. Preeti, for that excellent lecture. Are there any brief questions from the audiences?
Thank you for your It's rampant use of, thyroid, tests in general public. When self-refer themselves, without any indication also, or it's many times done as part of panel. At least in my own family, I can just give examples. People have been put on, endotoxin treatment for life on the basis of just biochemical investigation, and maybe the PSH is just reaching that cutoff of 10 or something like that. And they are completely, they don't have any symptoms. So how do we go about it? My question to you specifically also was, are there any age-related changes in the levels of PSH that should be taken while doing the test? And you have nomograms for different age groups of the levels of these thyroid hormones and PSH. Particularly, what's your comment about the elderly, 70 plus?
TSH does increase with age, but whatever studies are there, people have shown in normal population that the increase is say 0.4 to 0.5. People have looked at TSH is less than 50 and the geriatric population. The TSH doesn't rise more than 0.4 to 0.5. So probably when we are talking of geriatric population, 6 MIU per liter should be the cutoff. But as I showed you in my slide for that subclinical hypothyroidism, we never should say that the patient requires treatment for lifelong. There are certain indications where even the treatment